Good evening, everyone. I'm Mary Chaput with the Department of Aging and Disabilities Family Caregiver Support Programs. I welcome you all here tonight. And since we just have an hour, I'm going to go ahead and we're going to let Dr. Nicole Rochester get started. And Nicole, I just want to thank you again. We've had you at several of our workshops before, and everyone is very, very appreciative of you giving your time to us. So thank you.
Oh, you're very welcome. Thank you for having me. And good evening, everyone. I know that we can't all, I can't see you, you can see me, but good evening. My hope is that this will be interactive, even though we are, gathering together virtually. I'm Dr. Nicole Rochester. I am a board certified pediatrician by training, but I am a former caregiver to my late father. And as a result of that caregiving experience, I am now a professional health advocate and the CEO of Your GPS Doc. So I'd love to help family caregivers navigate the healthcare system. And I'm thrilled to be here with you. And I want to thank Mary and the Anne Arundel County Department of Aging for having me. So I am going to go ahead and share my screen. If you all have questions during tonight's presentation, feel free to use the chat or the Q&A box. And we'll definitely take questions at the end, but certainly if you have a question related to something that I'm talking about in that moment, then feel free to go ahead and type that and we'll address those questions also as much as possible. All right, so we are talking today about navigating medical care during a crisis. And there are many crises that we face as family caregivers related to the healthcare system, but tonight, I'm specifically going to be focusing on transitions in care. So I want to welcome all of you. I know that your job as a family caregiver is difficult. It's an honor, but it's also, very challenging. I always tell my friends and my clients and anyone that I speak to that, caring for my dad was the most amazing thing that I've ever done, but it was also the hardest thing that I've ever done. And I've done a lot of difficult things. So I want to thank you all for taking time out of what I know is a busy schedule to attend tonight's talk. So what is a care transition? A care transition is the movement of a patient between healthcare providers, between healthcare settings and the home. And these transitions are typically prompted by some type of a change in their medical condition that then requires a subsequent need for either a higher level of care or a lower level of care. And when we say home, that could be a private residence, but home for some of our loved ones may be an assisted living facility, a group home, or even a skilled nursing facility or nursing home. So there are lots and lots of transitions in care. And certainly, this slide just makes me think about my time caring for my dad, because as his health declined, we were back and forth between all of these settings. And so, ideally, we all want to have our loved ones at home, right? But even the transition from going from home to an appointment with your PCP or your primary care provider, that is a transition. And then sometimes that primary care provider may decide that your family member needs to see a particular specialist. That represents yet another transition. And then, if they have acute issues with their chronic conditions, or if they have, some change in their condition, then that may prompt yet another transition in care to the emergency room, or, God forbid, they may actually require hospitalization. And then what happens inevitably, particularly with older individuals, is that while they are in a hospital setting, they're laying in the bed, they're not getting up, they're not moving around a lot. And so very frequently, and this certainly happened with my dad, that hospital visit or hospital stay would then lead to the need for, transition to a rehabilitation facility or a nursing home for rehab, and then ultimately, hopefully, back home. And it's not always, perfectly circular like you see here, but the reality is that our loved ones in the journey of their care, they often are bouncing back and forth between each of these areas. And so every single time that there is a transition from one of these areas to another, there are potential problems that can result. So let's talk about some of those. What are the problems with these transitions in care? One of the problems is faulty communication among providers. And so, very commonly, what happens is that, if your loved one is going from their primary care doctor to a specialist, or, from the hospital to a rehab facility, or from home to the hospital, these providers don't often communicate with one another. And you all probably know exactly what I'm talking about. As an actual physician myself, this was one of the biggest pet peeves that I had as a caregiver to my dad, is that he had all of these different doctors. He had his primary care doctor, he had a cardiologist, he had a neurologist, he had an endocrinologist, he had a urologist, a psychiatrist. I'm sure I'm leaving some out. And each of them focused on their own area of expertise. And so they would make recommendations and prescribe medications, but very rarely, if ever, did they actually communicate with each other. And that caused significant problems with my dad. And that definitely causes significant problems every day with other patients when you have that faulty communication. One of the other problems with transitions in care is poor coordination of care. So, and excuse my dog barking, you all, I'm sorry. This is the nature of virtual presentations. Poor coordination of care. And so often what happens is that because those healthcare providers are functioning in silos, they're not thinking about the next step. They're not thinking about the care that needs to be coordinated. And so, for example, one specialist may be focused on the thing that they want your loved one to do, or the procedure or the medication, but they're not coordinating that with other important aspects of their medical care. And so you can find yourself sometimes with conflicts where, something that one provider is telling your loved one to do may actually be in direct contradiction to something that another specialist is telling your loved one to do. Another problem with transitions in care are information gaps. And we certainly found this with my dad. I see this with my clients. What happens is that information does not freely flow from one healthcare provider to another. So that the information that is present in your primary care doctor's office may not be easily transmitted to the specialist, and the information from the specialist is not always easily transmitted to the primary care doctor. We have these fancy electronic medical records, but they don't talk to one another. And so often, the test results that were done by one provider are not communicated clearly to another provider. And you end up with these information gaps. And a lot of times our loved ones are stuck in the middle, and they can end up receiving faulty medical care as a result of that. Another thing that happens during transitions of care is that the patients and the family members often receive inadequate education. And so as an example, if you're going from, home to the ER, when it's time to leave the emergency department, a lot of times those discharge instructions are not clear, and the family members and the patient may not have a clear understanding of what's expected, how to take new medications, when they need to follow up, other things that may need to be done. And so those information gaps and that inadequate education and preparation for that next phase of care can be extremely problematic. Also, the timing of these transitions in care is problematic because often these are urgent. A lot of times these are not planned transitions, particularly if you think about having to go to the emergency department or being hospitalized. A lot of times these aren't necessarily for scheduled procedures, but these transitions can actually come about as a result of some acute change in your loved one's medical condition, some emergency that happens. And so certainly when these things are unexpected, we don't have the ability to prepare for them adequately. And that can also cause significant problems. So I want to kind of go through these in a little bit more detail. And if we start with faulty communication among healthcare providers, some of the reasons for that are the hospitalist model. And I'm sorry, you all, I'm just going to hop for 1 second and close my door so that hopefully we can drown out some of the sounds of my barking dog. I apologize for that. So as many of you know that with the hospitalist model, what happens now, and almost all hospitals employ this, is that when your family member is admitted to the hospital, it's very unlikely that they are going to receive their medical care by the person that knows them the best, or the doctor that knows them the best, which hopefully is their primary care provider. And so the mere fact that there are hospitalists taking care of your loved one can be very problematic. Often with hospitalists, and I was a former pediatric hospitalist, so I know this model very well, it works well in the sense that you have doctors now in the hospital who solely focus on the medical care provided in the hospital. So because they're there all of the time, they form relationships with the other providers. They become very intimately familiar with how the hospital works. And so they can, more effectively coordinate the care within that setting. So those are the positives to a hospitalist model. But the negatives are that generally there is a shift model, so that the doctor that's taking care of your mom or your dad or your sister or your other loved one in the morning is likely not going to be the same doctor that's taking care of your family member in the evening. Similarly, you may have one doctor Monday, Tuesday, Wednesday. Your loved one may have a completely different doctor Thursday, Friday, and then yet a third doctor on the weekend. And so that just makes for, increased complexity and a lack of continuity of care. Also, in that same regard, there can be faulty handoffs. And so in an ideal world, when your loved one's care is being passed from one doctor to the next, there would be this very detailed handoff process where the new doctor coming on has all of the information that they need to adequately take care of your family member. But what we know is that unfortunately in real life, that just does not happen. Often there are things that slip through the cracks. Sometimes the doctors are making judgment decisions about what's important, what's not important. There are often electronic documents that facilitate that handoff, and just human error seeps in. And so sometimes medications may be left off, or very important tasks that need to be done, labs that need to be checked, those things may be left off. And so that can definitely contribute to problems and unsafe conditions in the hospital setting. And then there are also time restraints. And so, even in the hospital setting, depending on the volume of patients, the doctors don't have an unlimited amount of time. And so unfortunately, sometimes things will slip through the cracks just by virtue of the doctors having limited time to spend with reviewing your family member's chart in its entirety, and really making sure that those pieces of the puzzle are put together. And so these are all the ways that communication among the providers, particularly in the hospital setting, can be problematic. So if we talk a little bit more about poor coordination of care, we talked about the fact that these episodes or these transitions are often untimely and unexpected. The reality is that in the hospital setting, the discharge planning, in my professional and personal opinion and experience, is almost always inadequate and almost always untimely. Regardless of how long your family member has been in the hospital, it seems very common that that discharge decision seems to be made abruptly. And even in hospital stays that span, 1 week, 10 days, where they've had plenty of time to figure all of this out, it's not uncommon the night before a planned discharge for the case manager or the social worker to enter the room and say, okay, Mr. Jones, you're going to be discharged tomorrow, or to say to the caregiver, okay, we're going to be discharging your husband or your wife or your dad tomorrow. And then there's suddenly this long list of things that needs to be done. Even in the case where the transition is from the hospital to a nursing home or a rehab setting, often family caregivers are given very little time to make very important decisions in terms of, choosing facilities and those types of things. So that can lead to poor coordination of care. And then unfortunately, there's often an absence of teamwork. And so while your family member may have this huge medical team, made up of doctors and nurses and case managers and physical therapists and occupational therapists, a lot of times they're not working together and they're not acting together as a team. We talked about how they tend to function in these silos. And so as a result of that absence of teamwork and one person not really fully appreciating what the other person is doing, sometimes there's duplication of work, but more importantly, sometimes things slip through the cracks. We talked about those information gaps and how those are unfortunately very common in transitions of care. And so a lot of times there is either limited or sometimes no communication with the primary care provider. This is incredibly important, and this is a step that is often skipped. When your family member transitions from home to a hospital setting, as an example, in an ideal world, an effort would be made to have an actual conversation with your family member's primary care doctor to make sure that all of the information is intact, to make sure that a complete medication list is there, to make sure that the admitting team and the team that's going to be caring for them has all of the information that they need. And also, as it nears time for discharge, in an ideal world, there will be another communication with the primary care doctor so that he or she is aware of all of the things that happened in the hospital so that they can prepare to receive your loved one back into their medical care, and they can make sure that that transition is seamless. But unfortunately, for many, many reasons, that communication between the hospital-based team and the primary care doctor, or if they're going from a rehab facility or a nursing home back to the home setting, that communication with the primary care doctor is often either limited or it does not happen at all. And so that places a lot of burden on you all, on the family caregiver, to really make sure that you have all of that important information. Also, I mentioned this briefly earlier, but we have this fancy electronic medical record, which, as a physician, I was super excited several years back when we were told that we were going to be transitioning from paper notes to electronic medical records. And we were told that this was going to be such a wonderful thing for our patients because it was going to improve care, because, Mrs. Smith, who's been seen in this other hospital, and normally you wouldn't have access to her records, but now with this electronic medical record, you could open up this record and find out what happened, even at other institutions. You could find out what happened in that same institution, a year ago or 6 months ago. That has not proven to be the case. Certainly, if your family member is being readmitted to the same facility, then yes, that electronic medical record can be a wonderful source of information. And we have the ability to go back and look at x-rays and laboratory results and notes from doctors from previous hospital visits, and sometimes even from outpatient visits. But the problem is that even in 2021, there is no interconnectedness, there's no interoperability between different electronic medical records. So your primary care doctor may use one electronic medical record, your family member's cardiologist or other specialist may use a completely different electronic medical record, which may be completely different from the one in the local hospital where your loved one is admitted, and always will be a different system than what is used in nursing homes and rehab facilities. So because of that, these are all opportunities for critical information to be lost. Sometimes information in electronic medical records is copied, meaning let's say your family member was hospitalized 6 months ago. Well, maybe the doctor that hospitalized your family member didn't get a complete history, or maybe they didn't verify some of the information. And so that information is living in that record, but it's incorrect. And I'm going to share a little secret with you all. Sometimes doctors, again, in a quest to be more efficient, they will go back to a previous note and just copy information and paste it, thinking that, okay, this is past history, this hasn't changed, but sometimes that information is inaccurate. And so that can be incredibly problematic if inaccurate information is living in this electronic medical record. And instead of them, asking those questions fresh and new and getting information that is up to date, sometimes that information will just get copied from previous notes. And you can imagine how that can be problematic. Sometimes the patient history is incomplete. A lot of times our loved ones are going to the hospital for problems that may impact their mental status. they may not be able on their own to adequately share a thorough history, right? And certainly now with COVID, a lot of times, they are navigating those settings by themselves. And so that's extremely scary for me as a former caregiver and as a health advocate to know that for the last year, patients have been presenting for care without a loved one that can fill in those gaps, which I often did for my dad. And I'm sure that many of you do this as well. And so a lot of times this history that's being provided is incomplete. Also, even when the family caregiver is present, a lot of times the doctors and the other healthcare professionals are not leveraging that expertise. They're not taking advantage of the fact that this caregiver knows a lot of things, right? We are typically the experts for our family members and our loved ones, but a lot of times that expertise is not leveraged by the healthcare providers. And so unless we are, fairly aggressive and speaking up, then that can contribute to information gaps as well. If we talk more about inadequate patient and family education, we know this is a huge problem. Again, there's those time restraints, and this is going to come up over and over again, not as an excuse for healthcare professionals, but just as part of the reality. They are juggling so many tasks. Sometimes they're juggling lots and lots of patients. And so, when you have time restraints, things like adequate education of patients and family members often slips through the cracks. Often, this education is also not standardized. And so it would be nice if, based on certain medical conditions, based on certain diagnoses, that there would just be standard education that you could feel comfortable knowing if my family member is admitted for pneumonia, there is a standard set of instructions. There are standardized education materials that will be provided, that will be reviewed. But unfortunately, believe it or not, that does not exist. And so you're really at the whim of the person that's providing that education. And so if you happen to have a really, really good nurse who's very thorough and who values, the importance of that education, then you or your family member may get an amazing amount of education. But conversely, if you have someone else who maybe they're new at the job, or maybe they're having a bad day, or maybe they're stressed, or maybe they don't have a lot of time, or they're just winging it, because these things are not standardized, then sometimes really important information may not be passed on. And this education is so important. The education that is provided during these transitions completely impacts the amount of care and the quality of care that your loved one receives after they leave that particular setting. Also, sometimes there are language barriers. And so we know that, for some of us and for some of our family members, English may not be their first language. And so a lot of times, unfortunately, this information is not provided in someone's preferred language. A lot of times people aren't even asking what someone's preferred language is. And even in individuals who speak English, what we know is that there may be some illiteracy. And so many individuals may have difficulty reading, even in their native language. And also there's another issue of health literacy that we see even in, college educated individuals here in the United States. And so a lot of times if the information being provided is at a really high level, they're using big words, they're not using lay terms, then that can be a huge issue as well. If we talk about the timing, I've talked about the fact that these transitions of care are very, very unpredictable. And so, a lot of times there's not, because they're unpredictable, because they're unexpected, that just leads to all types of room for error, for gaps in knowledge, and for gaps in care. And it makes it so that we are not able to adequately prepare for these transitions in care in advance. So this is what's known as the Swiss cheese model, and it was developed by British psychologist James Reason, and it was originally used to analyze industrial accidents. And it led to fundamental insights about the nature of preventable adverse events. So even though this model was developed for industrial accidents, it has been used very frequently in medicine, in aviation, and in many other industries. And essentially what this model shows is that, in every single system, and this includes healthcare, there are holes. Each one of those holes, just represents human failings, breakdowns in the system. And so there are always some gaps, there are always some holes, there are always potential errors. But if you look at this yellow arrow here, what happens in an ideal situation is that if something is able to get through one hole, then it's deflected. Maybe there's a mistake that would have been made, but it's caught. Maybe the doctor writes for the wrong dose of a particular medication, but maybe the nurse catches it and doesn't administer it. And this happens all of the time within healthcare. But what the Swiss cheese model shows us is that every now and then, those holes, unfortunately, will line up perfectly. And what that means is that errors, just human error, things that happen in the system, are allowed to go all the way to the patient, which is your family member, your loved one. And that's what leads to the medical errors that we see in healthcare. So if we talk about these poor outcomes that can result as a result of these transitions and this Swiss cheese model, what are some of the things that happen? Why should we care about transitions of care? Well, one of the poor outcomes that we see are hospital readmissions. And so it is very common that patients are discharged from the hospital and then readmitted back to the hospital. Now, technically, if you look at from a medical standpoint, a quality standpoint, they consider anybody that is discharged and then hospitalized again within 30 days as a hospital readmission. And that's not just bad for the hospital. They actually get dinged for that, and there's money that is withheld from Medicare. But this is, more importantly, an issue for your family member, for your loved ones, because those hospital readmissions have been shown to be associated with significantly worse outcomes. There's also medical errors. I just talked about that. So, when we have these transitions, one of the poor outcomes is medical error. Every time your family member goes from one healthcare setting to another, there is an increased risk of medical errors. There can be medication errors. So, if your family member doesn't have an up-to-date medication list, if there were recent changes to medication, sometimes things were taken away, new medications were added, maybe a dose was changed. And a lot of times it's those intricate details that get lost during these transitions. And so when that information is not readily available, that can lead to medication errors. That can lead to essential medications that your family members should be taking that are not, or if their hospital or the rehab facility is relying on an inaccurate medication list, they may continue to give medications to your family member that in fact have been discontinued. Maybe those medications have been discontinued because of serious side effects or interactions with other medications. And so these things can be very, very dangerous for our loved ones. And then we also know that in these transitions of care, sometimes what results is a progression of the disease. So, and if we take diabetes as an example, or high blood pressure, sometimes these transitions of care and all of the errors that result from that lead to that disease progressing. So maybe their diabetes is no longer well controlled as a result of poor communication, as a result of the patient and the family not having a clear understanding of what they were supposed to do at discharge, as a result of medications being left off the list. And that can lead to complications. And those complications can then lead to, readmissions and future hospitalizations. So you can see how it can just lead to this vicious cycle. And then in the worst case scenario, these poor transitions of care can actually lead to death. So if we look a little bit more closely at the actual poor outcomes, admission to a hospital, I mentioned, within 30 days is the definition of a hospital readmission. And these hospital readmissions occur fairly commonly. It's estimated that up to about 20% of patients with Medicare are readmitted to the hospital every year within 30 days of a discharge. About 15% of Medicaid patients have those statistics. About 10% of patients with private insurance are readmitted to the hospital, and about 12% of patients who are uninsured are readmitted. So certainly we see the highest rates of readmission among individuals who have Medicare or Medicaid. If we look at medication errors, these are preventable adverse effects of medical care. Now, some studies have shown, this is a little bit controversial, which is why I put a question mark. There are studies that have shown that medical errors are the third leading cause of death after heart disease and cancer. And some studies estimate that up to 250,000 deaths per year are due to medical errors. Now, some of this information has come into question, and there have been subsequent studies that suggest that maybe this is an overestimate. But regardless of what the actual number is, we know that medical errors contribute significantly to morbidity, which are, disease progression, complications, and also to death. And, medical errors can include things like misdiagnosis. They can include things like undertreatment, but also overtreatment. And they also include medication errors. And whether or not that medical error makes it all the way to your family member or not, based on that Swiss cheese model we talked about, just the mere fact that these errors exist and that they are more likely to occur during these transitions of care make them very, very worrisome. Medication errors, of course, are extremely common, and they're also extremely dangerous. And that's defined as an error anywhere along the pathway from when a prescription is written, when an order is entered into the computer, to when your family member actually receives that medication. And there are certain individuals that are more at risk for medication errors. So those are going to be people with complex medication regimens. If I use my dad as an example, at one point my dad was on, I think we counted like 22 different medications. Some of them required him to take with food, some of them without food, some in the morning, some at night, some of them couldn't be combined together. And so anytime you have a patient with a complex medication regimen, you're just asking for trouble. You're just asking for something to happen that can lead to an error. Other individuals that are at increased risk for errors with medications are individuals with low health literacy, individuals who may not completely understand their medical care, their diagnosis, and how they're supposed to take their medications. Also, people who are not native English speakers have been shown to have an increased risk of medication errors, as well as patients with mental health problems. If we look at disease progression or complication, these are usually due to delays in care as a result of these transitions, gaps in care, or even complete lapses in medical care. Another thing that happens, more common than I'd like to admit when we have these transitions in care, is that test results are actually lost. There have been studies that have looked at how often this happens. And, not uncommonly, a test result or something that may have been ordered in the hospital setting, as an example. Well, sometimes that test result is not going to be processed in that hospital. Sometimes, depending on the complexity of that particular lab, it may be sent out to an outside facility. Sometimes these labs may be sent to facilities that are, many, many miles away, many states away. And so those results are still pending when your family member leaves the hospital. And guess what? Sometimes it's not clear who's responsible for following up on those tests, because the doctor that ordered that test is likely going to be the hospitalist or maybe one of the specialists, but that doctor is no longer taking care of your family member once they leave that setting. And so while that doctor may get some type of notification about that lab result, sometimes they don't. Sometimes these things slip through the cracks. And these abnormal lab results just sit in oblivion in these electronic medical records. And sometimes that doctor that actually ordered it either doesn't get the result, they forget to follow up on it. They don't always reach out to the patient or to the primary care doctor. And so there are instances when very important lab results just get lost in these transitions of care. Also, sometimes these tests get repeated unnecessarily. That can lead to whole other problems related to, insurance and payments. Maybe your family member just had a CAT scan of their head, as an example. But then maybe 4 or 5 days later or a week later, they find themselves in a different emergency room. And maybe because of the way that they present it, because of their symptoms, they're getting another study, or maybe they're getting another lab result that they just had done in the primary care doctor's office. And while it's important in some cases that those test results be repeated, sometimes that's just a duplication of work, and that can lead to further confusion. And then, as I mentioned, there is an increased risk of death every single time our loved ones go from one of these sites to another. So that's all the bad news, but I can't leave you there. Let's talk about things that we can do to improve these care transitions. And some of these are things that the medical team should be doing. And when I give these talks, I always want to make sure that you as the family caregiver is aware of what the medical team should be doing when they are managing your loved one, because that way, when you're aware of what should happen, you have the ability to question those steps, and you have the ability to notice if it's not being done, and to then act on that when you're advocating for your family member. So medication reconciliation, what that means is that is a process that is supposed to happen every single time your family member goes from one setting to the next. And what that means is that is a process where the doctors and the nurses are supposed to do a complete review of all of the medications that your family member is taking. Now, usually they're going to do this, or they should do this, by obtaining a history. They should ask the patient if they are able, to articulate this information, what medications they're on. Now, certainly if your loved one has been in that setting before, they have the ability, the healthcare professionals, to go into that record. And what they should do is to look at the medications that were listed the last time your family member was in that setting, if applicable, and then literally go through line by line and say, Mrs. Rochester, are you still taking aspirin? Are you still taking atorvastatin? Are you still taking, this particular medication? And give your family member an opportunity to say, oh, no, I'm not taking that anymore. Or, I'm not taking 20 milligrams anymore. I'm actually taking 40 milligrams. I just saw my doctor 2 days ago, and he increased that dose. They also should be relying, again, on the primary care doctor. There should be communication between, the hospital or the emergency room and the other healthcare providers to ensure that this medication reconciliation process is thorough and accurate. Another way to improve care transitions is that the care that is being provided should be patient and family centered. What I mean by that is that the healthcare teams need to realize that the one constant in all of these transitions is the patient and the family caregiver. And so often as family caregivers, we are that single source of truth. When this information is scattered, when there are information gaps, when the information is inaccurate, we are the ones that typically have the information. And so if the care that is provided acknowledges that and ensures that the patient and the family caregiver are made to be an integral part of that medical team, then we can actually serve as safety mechanisms to offload some of those concerns that I've mentioned before. Another way to improve care transitions, again, is early and regular contact with the primary care provider. At a minimum, there should be some type of contact made at the beginning of the transition and at the end of the transmission. So if we talk about hospitalization, at the time of admission, and then again at the time of discharge. But sometimes it may be necessary to have additional points of contact in between. If the care isn't going the way it's expected, if there are complications and things of that matter, that's always another good time for the healthcare team to reach out to the primary care provider. We talked about care coordination. And so from the very moment that your family member is either hospitalized or sent to a rehab or nursing home facility, there should be coordination of care where the doctors and the nurses and the physical therapists and the speech therapists and the social workers and everyone is at least taking time to communicate with one another, because we know that each one of those caregivers has different information. the nurse is often spending the most amount of time with our loved ones other than us. And so he or she often has critically important information that they can share that the doctor may not be able to gather just by looking at the chart, looking at the vital signs, looking at the lab results. So those opportunities to communicate and to coordinate that care are extremely important. Another very important aspect of improving care transitions is patient and family education. And so this needs to be thorough. Ideally, this needs to be timely. It shouldn't be something that's rushed on the day of discharge, which is usually what happens. Your loved one's getting ready to leave, and suddenly, you're being presented with all of this information. Maybe you're getting some written information if you're lucky, but it's often very rushed, and it's usually inadequate. It's not often thorough. So this education should be thorough. It should be comprehensive. You should have an opportunity to ask questions. And there's a very key element of patient and family education that is often left out that I want you to be aware of, and that's called teach back. What teach back means is that anytime that healthcare professionals are communicating with patients and their family caregivers, there should be an opportunity for teach back, which simply means this: the healthcare provider, after they've finished their spiel, they should look at you or your loved one and say, okay, can you repeat back to me what I just said? What was your understanding of what we just talked about? Let's say it's wound care. Maybe there is a wound and you're going to be the one taking care of this wound when it's time to go home. And maybe a wound care nurse has come into the room and has gone into, the steps that you and your family member are going to need to take to keep this wound clean, to change the dressings. Maybe there's certain ointments and things that need to be applied. But rather than just go through those instructions and then hand you a piece of paper and walk out of the room, what they should say is, okay, let's talk about this. Tell me what your understanding is of what we just talked about. Repeat back to me what I just said. You'd be surprised how that opens up opportunity. And in many cases, it brings to light certain gaps in information, certain things that weren't clear, things that may have been misinterpreted. And that allows you as the family caregiver and your loved one and the healthcare provider to engage in a more meaningful dialogue. So that patient and family education is extremely important. Also, the discharge plan should be comprehensive. It needs to incorporate all of the medications that your family member is supposed to take. It should incorporate, when they need to follow up, who they need to follow up with, what's important, what are some signs that things are not going well? What should you look out for? When should you come back? When should you call your primary care doctor? All of these things should be included in that discharge plan. And then in some cases, it may be necessary for home health to be involved. Maybe there's a home health nurse that needs to come out to the house to assist with medications, to assist with wounds, to make sure that you as the caregiver are up to speed about what needs to be done. Maybe there are other needs. Maybe there's a home physical therapist that needs to continue therapy with your family member to prevent falls and things of that nature because of weakness. So all of these things need to be included. And then that family presence is key. And I have an asterisk here because in my opinion, particularly as a health advocate, I believe that family presence and advocacy is the most important part of this care transition. Making sure that you as the family caregiver, again, as part of that team, in the center of that team, that there's regular communication with you, that you have an opportunity to communicate with the team and express your concerns, and that you are able to strongly advocate for your loved one. So with that, I want to share with you the GPS system that I use for navigating care during a medical crisis. And this is definitely something that you can use not only during a crisis, but anytime you find yourselves navigating healthcare for your family members. So the GPS system is G, which stands for gathering information, P, which stands for positioning yourself as an expert, and S, which stands for speaking up. And we're just going to briefly go through each one of these. So again, the G is to gather information. One of the most important ways that you can effectively navigate the healthcare system, navigate these care transitions, and effectively monitor and manage the healthcare for your family member is to gather information. What I mean by this is making sure that you are familiar with what should happen during those care transitions. So we just talked about some of those things that should happen related to discharge, a thorough and accurate discharge plan. We talked about patient and family education and using that teach back. So now that you're aware of what should happen, that's part of that information gathering, because when we have knowledge, we have power, right? Another very important aspect of gathering information is asking questions. I cannot stress this enough. I hear so often from family caregivers that they sometimes don't take advantage of opportunities to ask questions. They are worried about taking up too much time. They often are sensing the body language of the healthcare provider who may be, rushing through the visit or walking toward the door. And so you have this question that's really important, but you don't want to, interrupt them. No. I encourage you all to please, when you have questions, to please ask them, because that is the most important way that you can stay informed about your family members' medical care and about their medications, about their diseases. And that gives you the tools that you need to effectively advocate for them. So some of the questions that you should always ask is, what is the diagnosis? Every single time your family member goes to the doctor, to whether it's a primary care appointment, an urgent care appointment, whether they're in the ER, they're hospitalized, you always want to make sure that you understand what is the diagnosis. Now, in many cases, our loved ones may have multiple diagnoses, but usually there are one or two primary reasons that you brought them to that visit. And so it's important that you have a clear understanding of what that diagnosis is. The next question you need to ask is, what is the treatment? And you need to make sure that you have a clear understanding of all of the recommendations that the doctor or the other healthcare professional is recommending. That treatment may be particular medications, it may be a change in medications, but it also may be things like dietary recommendations. They may recommend that your loved one stop eating certain foods or maybe start eating certain foods. There may be lifestyle modifications that need to happen. Maybe they want them to start exercising. Maybe they want them to stop exercising temporarily. And so the treatment for that medical condition is extremely important. That treatment may also involve, certain tests. Maybe there is a CAT scan or an MRI scan or labs that need to be obtained. The other thing that you need to ask is, how will you know if the treatment is working? A lot of times when our family members are prescribed medications, as an example, we don't really know what that end goal is because it's not often communicated well. Also, if there's a particular condition and it's being treated, it's important to know how will I know that this is working? What are some of the signs that will let me know that my loved one is improving? And also a timeline. When should I expect for these changes to happen? Should he get better in 2 days, or is it going to take 2 weeks? And that can help you decide as you monitor your loved one when you need to contact someone if you're concerned, and when you may need to seek additional care. When you're in the midst of these care transitions, it's always important that you understand who is in charge of the team. Particularly in the hospital setting, there's often lots and lots of doctors, but there's always one primary doctor, it's usually the hospitalist, that is in charge. If your loved one is being admitted for surgery, then it's probably going to be that particular surgeon. But there's always one person. And the reason that information is important is that if you find yourself in a position where there are multiple people involved and different recommendations are being made, you need to know that one person that should be coordinating that care and that should be taking into account all of those recommendations and making sure that they really meet the best interests of your family member. You also want to know what specialists are involved. Is there a cardiologist that's being consulted? Is there a surgeon? Is there another specialist that is being consulted, so that you are aware of all of the many people that are managing your family members' care? Another really important question that you need to ask are what are the discharge criteria? This is incredibly important. From the moment that your family member is hospitalized, you want to be asking what needs to happen for them to go home. Discharge planning should not take place on the day of discharge or the night before discharge, but a good medical team should be thinking from the beginning about the things that need to be in place in order for your family member to have a safe transition. And similarly, you should be thinking about those things and asking those questions. When you do that, it allows you to have an active role in that transition. So if you know, as an example, that your family member was hospitalized with pneumonia, and right now they're getting IV antibiotics, maybe they're getting IV fluids, maybe they're needing some oxygen, but you know that in order for them to go home, they have to be off oxygen, they have to have an oxygen level that's greater than this particular number, they need to be able to, walk 4 feet in the hallway, whatever those discharge criteria are, then you as the family caregiver can keep up. And as they begin to check those boxes and as they begin to accomplish those goals, then you are aware of the fact that, okay, he or she is getting closer to discharge. And that just allows you to be much more proactive. You also want to ask about any special equipment. If the doctors and the healthcare team have decided that your family member is going to need a walker or a wheelchair or home oxygen or some other piece of equipment, it's important for you to have that information ahead of time so that you can be involved in whatever needs to happen in order to obtain that equipment prior to discharge. And then another question is, ask them, have you spoken to my family member's primary care doctor? A lot of times that may be unexpected, but that can be a trigger that will, remind them, oh yes, I do need to do that. So it's totally fine for you to ask that question. Now, the P in the GPS is to position yourself as an expert. What that means is that you are the expert. And so position yourself as such. That involves taking steps so that you are knowledgeable about your loved ones' medical conditions, about their medications, the surgeries that they've had, the doctors who are taking care of them. I've already explained to you all of the ways that these important pieces of information can fall through the gaps. And so you as the family caregiver, you are that expert. And a lot of times you may be the only one who has that accurate information. So making sure that you have that information, that is readily available, either in a notebook or on your phone or however you prefer to keep up with that information is incredibly important. If you have the ability to be in the hospital room with your loved one, taking notes also positions you as an expert. Whenever a doctor or another healthcare professional enters that room, that is your cue to start taking notes. Because in the moment, a lot of times things are tense, everybody's stressful. And when you leave that appointment or when you go home from that hospital stay or that rehab stay, everyone's trying to remember what was said. Those discharge instructions that are given are often, woefully inadequate. And so a lot of times it's your notes that you took in the midst of those conversations that will be incredibly important. And then the S is to speak up. Speaking up for your family member is the best way that you can advocate for them. It absolutely leads to improved care during these transitions and otherwise. If there is misinformation, if the team of doctors comes in and they mention a particular procedure that they say your loved one had, and that's not true, or if they mention a particular medication, or if the nurse is about to administer a medication and you think there's a mistake, sometimes the doctor will tell the family, we're going to stop this particular medicine today. And then, the next morning, the family member may be the one to notice that the nurse is about to give that medication that the doctor said was going to be discontinued. So again, clarifying that misinformation and speaking up, asking clarifying questions, saying in that example, yesterday the doctor said that they were going to discontinue that medication. Can you please go back and check? I thought that that's what they said. And asking those clarifying questions can be incredibly important during these care transitions. And then escalating concerns, asking to speak to the doctor when necessary. Sometimes you need to escalate that. Maybe you need to speak to the charge nurse. Maybe you need to speak to what's called the administrative coordinator. Sometimes if you have a specific complaint, you may need to go all the way up to the director of a particular hospital unit. If it's a rehab facility or a nursing home, you may need to contact the ombudsman. Everyone has a boss. There's always someone above the person to whom you are speaking. And as the family caregiver, it's just really important that you are comfortable using your voice and speaking up for your loved one when necessary. So these are just some of the ways that you can escalate your concerns in these particular healthcare settings. All right, so I want to wrap up by briefly talking about COVID. This has been devastating to all of us in so many ways, but as a former family caregiver, I have not been able to stop thinking about the trauma that has resulted from you all, from the family members, not being able to accompany your loved one to the emergency room, during these hospital stays, to not be able to visit them in these rehab and nursing home facilities. And based on everything that we've talked about today, we know that there are errors that are, just destined to happen. And that often we as the caregivers are the one who would, mitigate some of those errors. Not to mention the fact that many of us have lost loved ones and not been able to be there, during that final transition. So I want to share with you, even though some of the hospitals are starting to relax their visitor restrictions, I want to share with you how you can apply this information, even as we continue to be in the midst of a coronavirus pandemic. So it's really important that you learn how to advocate for your family member remotely. And some of the ways that you can do that is to contact the hospital. Even though you can't physically be there, you absolutely need to be a pest, particularly a polite pest, but a pest during this COVID pandemic. And so I sincerely recommend that if you have a family member in the hospital, that you contact their nurse at least once a day. You can call the nurse's station, make sure that you have the number to that nurse's station, and call them at least once a day, if not twice a day, just for updates. Just by virtue of you making those phone calls and then becoming familiar with the fact that you're calling on a regular basis, that puts the medical team on alert. And it lets them know that there's somebody checking on this particular individual. Now, everybody should receive excellent care, right? Regardless of whether they have a family member calling to check on them. But I'm here to tell you that it makes a difference when the team knows that there is an actively involved family member. The other thing you want to do is that even though you may not be able to be there physically, make sure that your name and your contact information is listed in the chart. You can do that when they go to the emergency room by calling the ER. Once they're admitted, again, by calling up to that nursing station, asking to speak to your family member's nurse and asking them to document that information on the chart so that it's very clear if there's a change in their condition, that they know exactly who to contact and how to reach you. It's also totally within your right to request a call from the doctor. If the situation is tenuous, if your loved one is particularly ill, or if you just want more information that maybe can't be provided by the nurse, you absolutely have the right, and you should exercise the right to get a call from that doctor when necessary. When you are engaging in these phone calls, I encourage you to take copious notes so that you have that information in front of you and you can refer to that as needed. The other thing, and I think a lot of facilities have done a good job with this, is that requesting video visits so that your loved one can see you. This is particularly important with our elderly family members and those with dementia who are already going to be really disoriented by being in a new situation and a new environment and not having that familiar face in front of them. So utilizing technology like iPads and other tablets or even telephones can be a really important way to allow you to be in contact with your family member and them with you, but it also gives you that pair of eyes so that you can see your loved one. And you may pick up certain things about their speech or their behavior. You may notice that they're not being groomed properly, or a number of things that can help you communicate more effectively with the team. And then regardless of the COVID precautions, you should request to be physically present at the time of discharge so that you are sure that the discharge plan is clearly communicated. All right, so in summary, We talked about all of the ways that these care transitions are problematic. We talked about the fact that, there's medication errors, there's information gaps, there's a poor coordination of care, there's faulty patient and family caregiver education. And we talked about how you as a family caregiver can use the GPS system to help you navigate these transitions of care, gathering that important information, positioning yourself as the expert for your family member, and then speaking up and advocating for your family member when necessary. So I hope that this information has been helpful. I know we're at 8 o'clock, but I am definitely willing and able to stick around for a few more minutes because I definitely want to make sure that I answer any questions that you all have. I have my contact information there, so you can feel free to check out my website. I'm also on Facebook, Instagram, Twitter, and YouTube if you search Your GPS Doc. So I encourage you to visit me on those channels where I share a lot of useful information. So Mary, with that, are there any questions?
I don't have a question right now, but I have a comment that this has been highly informative, and thank you for your time and your insight.
Oh, you're very welcome. Thank you.
And I do know, Nicole, one of the questions that usually comes up is, would you be willing to PDF your PowerPoint and send it to me for me to send to the folks that attended?
Sure, I can definitely do that.
Okay, thank you. It's excellent, and I learned a lot. It's a shame that the system is as it is. Yes, but it is, and so we need to be prepared.
Absolutely.
Yeah. So thank you everyone for coming up. Let's see, I have another thank you so much, greatly appreciate it, and I will connect with you. So wonderful.
Awesome. So you're very welcome. Thank you all.
Thank you, and take care. And for my caregivers out there, remember to keep taking care of yourself, because you're not going to be able to do all the things that Nicole talked about if you're not taking care of yourself first.
That's right.
Okay, somebody says they have a quick question. So
sure, absolutely.
How do you advocate for your loved one when the nurse doesn't call you back?
That is a great question. So I have a couple of answers to that. Let's see, how do I say this nicely? This is where you may have to be a little more forceful. And again, it's a fine line, because I know that the last thing we want to do as family caregivers is to alienate the people that are taking care of our loved ones. And I hear this all the time. There's this fear that if I make this person angry, he or she may take that out on my family member. First of all, that we should not have that fear. But this is where you have to be a little bit more assertive. I'll use the word assertive to put it nicely. And what I would do is, like I mentioned earlier, this is where you want to escalate your concerns. And so if you've made several attempts, you've made several requests, and that nurse has not contacted you, what you can do is call back to the nurse's station and say, hi, give your name. I'm so-and-so's, family caregiver, and I would like to speak to the charge nurse. And then when that charge nurse hopefully gets on the phone or calls you back, you share with the charge nurse, for the last 2 days, for the last 12 hours, I have made multiple phone calls. I'm very concerned about my mom, my dad, whoever your family member is. And I have requested that the nurse contact me. Now, I will say, this is not an excuse, but, particularly at the height of COVID, the nurses and the doctors were just so swamped and so overwhelmed that it was a challenge getting back to family members. In the past, they would know that when they walked into that room, they could have that dialogue there. Now they're having to squeeze in how to make these phone calls and still deal with patient care. But that should not be our problem. That should not be your problem. So this is a situation where you want to escalate your concerns. And if the charge nurse is also not responsive, then every hospital unit has what they call an administrative coordinator. They all have a unit director. And so you literally just keep, going up that chain of command. And, there's patient relations. Those are the people that ultimately manage complaints. And then, at the very top, there are, boards of nursing, there are boards for physicians. Usually it doesn't get that far, but I think just being persistent and being assertive, and after you have asked politely a few times, that's when you want to start to escalate those concerns.
Another question, Nicole. What about patient confidentiality? When my son over 18 was in the hospital, some of the providers were not as forthcoming with information they had to ask my son for permission to share, even though he had given permission earlier.
So the question, I'll address this generally, but if they can type in the chat how their son gave permission. So this is, HIPAA, as you all are probably aware, is a federal privacy law. And it's an important law because we don't want our information or our family members' medical information just being shared, freely without our permission or without their permission. However, I will share with you that unfortunately, the HIPAA privacy law is probably one of the most misinterpreted and misused policies when it comes to healthcare. It was never intended to prevent, information sharing that's going to benefit the patient. It was certainly never intended to be a barrier between someone who is a family caregiver and their loved one. And unfortunately, though, it is often used that way. But by law, once an individual is either 18 or if they are an emancipated minor, which varies by state, but like here in the state of Maryland, as an example, if once someone is pregnant, if they've had a baby, if they are seeking treatment for substance abuse or psychiatric care, there are many situations where even someone under 18 may be considered an emancipated minor. So having said that, legally, there is a process where that family member needs to give permission. The best way to do this is in writing. And it's one of the things that I recommend to my clients, particularly in light of COVID and us not being able to physically be there, is that all of you can Google HIPAA authorization form. There is a generic form that can be used across states, across healthcare facilities. And we've done this in my family. I've had my husband and my 2 adult daughters sign this form. I've signed the form, giving permission so that if any of us are in a hospital setting or, we're having to seek care, we can show this document that we have already signed that gives written permission to share information, with your dad, with your mom, with your spouse. So that's something that's really important. Anytime you can have that in writing and you can present that to the medical facility at the time that you present, that's the best way. But certainly if your son gave verbal permission, even then, that should serve as enough. But what happens is sometimes that verbal permission is not documented by whomever he gave the permission to, or sometimes it's buried in that electronic medical record that we talked about. So let's say your son went into the emergency room and he told the nurse, as the nurse was taking all of his information, I want you to share this information with my mom. This is her name. This is her phone number. Well, that may be buried in that nursing note, but if it's not put somewhere that's clearly visible to everyone, then it may get lost. And so if it's not, clearly put on like the problem list or the face sheet, then individuals that are taking care of your son after that initial visit may not notice that he did indeed give the healthcare professionals permission. So sometimes patients have to repeat it and say, yes, I gave the nurse permission, I gave the doctor permission, but taking that extra step to either have it in writing or to have the patient say, I'm giving my mom, my dad, whoever permission, would you please document this in my chart in a way so that it is easily visible to everyone on the medical team? And that just goes that extra step.
And it sounds like that this young man and his mom both did sign something. So apparently, again, it got lost somewhere in that system.
Yeah, I'm really sorry about that. I mean, the only thing in that situation is, if your son is able to communicate, just to have him reiterate that, and I've even had to do that as a health advocate. I've had clients who have signed HIPAA authorization forms. I call the hospital and they refuse to give me information. And then I have to, they put me on hold and they go into the room and say, clarify with my client, yes, I've given Dr. Rochester permission to, for you to talk about my information. So sometimes, despite our best efforts, because of all of that lack of coordination that I talked about, these things can kind of slip through the cracks.
I don't think we have any more questions, Nicole. So again,
Okay.
thank you very much. And
You're very
thank all
welcome.
of you for coming here tonight. And I will, as soon as I get the PowerPoint from Nicole, I'll send it out to all the attendees. And it usually takes us a couple of days to get this up on our website. But, you know, if you want to relook at it again, because there was a lot of information in here, just keep checking our website on the caregiver page, and you'll be able to watch it over again. So thank you, everyone.
Good night, everybody.
Good night.